All right. I have the privilege tonight of introducing our speaker for the night, Dr. Ian Hahn. Dr. Hahn is the director of the Retina Service and associate professor in the Department of Ophthalmology and Visual Sciences at the University of Iowa. He received his MD from the Duke University School of Medicine, where he was a Howard Hughes Medical Institute Research Fellow. He completed ophthalmology residency and vitreoretinal surgery fellowship at the Wilmer Eye Institute of Johns Hopkins Hospital, where he also served on faculty as the Stephen J. Ryan, MD, Assistant Chief of Service. Dr. Hahn is a dedicated teacher and mentor who has been recognized with numerous awards for excellence in clinical care and education. As an active clinician scientist, Dr. Hahn leads multidisciplinary teams in the retinal imaging and modeling laboratory and the Retinal Transplant Surgery Laboratory at the University of Iowa Institute for Vision Research. Dr. Hahn, really thank you so much for joining us tonight.
Yeah, it's great to have everybody. Hopefully you can hear me okay. So, all right, I see nods. Awesome. Well, I just want to say thank you for spending an evening with us, basically. And I never thought I'd be somebody who'd be sharing some stories and other experiences with eager young people like yourselves who have a lot of runway ahead of you. So I'm very envious of your position. I think you should really soak up everything that you have. And kudos to the entire team for putting this type of opportunity together. I wish I had this type of opportunity as well when I was going through training. So hopefully you'll get something from this evening, and it's meant to be pretty casual. I was trying to think of a good topic for Nick's suggestions, and I think one thing that's been on my mind a lot is you blink and suddenly I have gray hairs, and I've in medicine for a little bit now, and it's hard to remember what it's like actually sometimes as a medical student. So I thought what I would do is actually share a couple stories. One is a history story that's probably pretty relevant to the upcoming events, including on Monday when we have a solar eclipse. And I think that story I really like because it's a history story that bridges essentially 80 years and two friendships. And then if we have time, I'll share a second rambly story about some of my mentors and how everyday science and relationship kind of works. And hopefully that'll give you a little bit of flavor of what life is like in medicine with medicine and relationships. I think that's really the key theme that'll hopefully come through as some of these stories are told. And then up on the screen are a lot of my friends in the field. Like on the right is a whole panel montage from a single meeting at ARVO, Association for Research and Vision in Ophthalmology, which is coming up. So you just get to see a lot of people over the years. And then some faces that you'll see throughout the presentation include Glenn Jaffe up in the top left, who is my mentor in medical school. Mort Gober, I'll talk about my residents from Hopkins, including Tom Johnson that Nick was just talking about. Some of my closest friends at Iowa, Bud Tucker and Ed Stone, the Iowa Retina team down in the bottom, and then some of the chiefs who trained me. So it's just really amazing time in medicine. I hope you get a flavor of it. Okay, hopefully you guys can see this. And let me see if I can get my, whoops, that's not what I wanted to do. Okay, well, a few themes I hope will come out. I'll just give you the themes up front. They might seem a little bit trite, but hopefully they come through. One is what I just said. Medicine is really an amazing pursuit. You guys are really, really lucky to be pursuing this type of passion. And I hope you find every day is precious, basically. It's a new opportunity. Medical school can be a difficult place to find belonging because you're jumping from one thing to another, a different rotation or clinic. But every day is fresh and new. And if you take it with that attitude, it's also absolutely an awesome time. And then one thing that you'll see is that you should seek wisdom from the wise. And I think that's been the story of my career. I never knew exactly what I was going to do with my career. Hopefully I'll come out in story number 2. But the best thing that I've done probably is find people who have experience and wisdom well beyond me and trust them. And if you trust them, they'll lead you in a good direction. This is why the Van Gogh painting is up on the right. The closer you get to the wise, the more you see their flaws. So kind of allusion to the title. Finding the real is identifying who's worth the time, who's worth the investment, who's going to guide you the right direction. And then I find that there's a lot of perfection in the world these days that's projected. But the closer you get somebody, and the closest friends and mentors that I have, actually, you actually come up and see their brushstrokes and some of the imperfections that are present there. They look admirable from afar, but up close, it's like, wow, there's a lot of that painstaking effort that made them who they are. And some of the most important people in my life, I respect them more because of the flaws that they have. And then the last kind of section of advice is that science advances through relationships more than experience. This is paraphrased from Ed Stone. So a lot of the things that we've accomplished has been in our field has been through relationships, and hopefully you'll see a little bit of that. And then some of the most amazing people that I know who have made a mark in the world, I hate to say, don't really have work-life balance necessarily. They are like a father or a husband or an ophthalmologist is what I was identify myself as, but they actually find a way to take all of their identities and be that all the time. And what I mean by that is some of the most amazing people can synthesize hobbies and activities with their family and have this eureka moment about the work that they do. So they're separated in time and space with what they do, but they actually synthesize everything together in a beautiful, elegant way. And then focus on building relationships in your journeys. I'll share a few of the relationships that I've had. And then this is an opportunity to share our journey. So hopefully I'll hold some time for you guys at the end to ask whatever questions that you like. I'm pretty candid and honest from there. So that's the framework. Okay, so a couple stories. So I'll start with this one picture. This is an amazing picture, but Nick asked about AI and some other stuff. I'll weave some AI stuff in, but I guess the question for this, just as a little teaser, is this photograph real or fake? And I'll say it's a beautiful photo. It might be a little jarring just because it's not in color. And there are a few aspects of this that are really interesting. Like I immediately noticed this guy's cool hair. He's got glasses pretty on trend. Like maybe you guys are wearing glasses very similar. Like Kurt's wearing glasses like this right now. It's good. He's got a warm smile. And let's see, he's got a pretty professional shirt right there and a pretty sweet sweater and awesome pipe. And he's got great lighting over here and a nice book, but it almost like looks blank. So I'm not sure if he's covering up something. And then a lab coat in the back. And then this is the fun part is this is an anachronism for the screenshot that I took. It's in the wrong place basically there. So this is a provocative photo that I'll get back to, but this is a real person from the 1940s that'll be a key part of the story. And I'm trying to figure out how to get all your faces back. Oh, well. Okay, maybe we'll get, oh, here's the gallery. All right. So what I hope to present is a little bit of perspective today. And I think the perspective starts with where you are today, right here at this photograph. And then the story starts all the way from a patient that I saw just yesterday in clinic with diabetes with this fundus image. So if you're interested in ophthalmology, it's amazing. Ophthalmology, you can look in an eye, get a sense of somebody's systemic disease. And the residents at our ophthalmology clinic would take a look at this and say, there's a color fundus photograph, the media are clear. They point out the optic nerve, some tortuosity of the vessels, some sclerosis of vessels, and lots of different pock marks in the retina from laser. And in reality, though, what I like about this is that even within this patient's eyes, there's a very colorful story about this patient all the way from the beginning. So I want to tell you a little bit of a story for all the way back from 1945, because this patient's story is woven together with my career and the photograph that you just saw. So here's the beginning of story number one. So what happened in 1945? If you Google this, you get a lot of wartime images. So sorry for the scariness there. But July 9th, 1945. This is a post-Germany surrender, Pacific Front still going. And the reason I decided to share this story is we've got a solar eclipse coming up on Monday. And July 9th, 1945 had a solar eclipse that was very momentous in history. In fact, what ended up happening is a bunch of people in Europe burned their retinas. And here's a picture of solar retinopathy. So I was just interviewing with media outlets today, telling people not to stare directly at the sun. Don't do this, you'll get a burn in your retina. It leaves a hole right through the middle. So how did this event, there you go. How did this event lead to a momentous change in ophthalmology? Well, enter this guy. This guy is Mort Goldberg. He's an amazing friend and mentor. He is one of the legendary ophthalmologists of our field, and he's a former chair of Hopkins, amongst many different things. So I know of this solar eclipse from 1945 from Mort Goldberg. And how I know about this, here's some stuff about Mort Goldberg. He's got the highest honor, the Nobel laureate, or sorry, Academy laureate, which is basically like being the Steven Spielberg of ophthalmology. And just in case you didn't know, we actually don't have a Lifetime Achievement Award for ophthalmology. And sorry, skip this part. So basically, he's like a Lifetime Achievement Award winner. in ophthalmology at the level of like a Steven Spielberg. And he was basically one of the main influences that I had at Hopkins. And one of the most momentous parts of my careers was when he let me know that he was writing a perspective piece for the Ophthalmology Journal. It's very rare to have a historical piece in a major journal, and this was a number of years back, and he was asked to write one. And then the even more amazing part to me was he actually came to me when I was chief at Hopkins and said, "Can you please take a look at this and give me your candid, honest thoughts?" And I was kind of flattered by this because I was reasonably young in my career as first-year faculty member. I didn't know what this senior professor emeritus person who's a legend in the field would want my opinion for. So I basically said sure because he said yes to everything, and but this is what I was thinking. I don't know why you need my perspective, but the reality is like we had built an experience together by writing a number of papers, and I think he saw that I was a good thinker. I was interested in coming up with good answers, and I was critical. So because of that, he sent me the entire manuscript and said, "I want your candid, totally honest thoughts. That's really what I want, is as candid as you can be to let me know what I can improve." And it's pretty intimidating if you're a junior person and a senior person who's a legend asks you for advice, but I realized that's what he wanted. So I edited the crap out of it. So sorry, Dr. Goldberg, I sent him all these things with a lot of red ink. And eventually, this is what was published. He actually took a lot of my suggestions and was very grateful for them. And so this is a legendary article that you all should read if you screenshot this and look it up later. But it's in the Academy Journal for Ophthalmology. It's personal reminiscences from three legends of the field, including Mort Goldberg, about various innovations in ophthalmology. So I helped contribute to this, which is kind of cool. And so far, it's one of the highlights of my career. And also, you can actually tune in and check out. I wrote a tribute article too, because Goldberg is perhaps best known for describing a variety of retinal vascular diseases, including sickle cell, the staging system of which is named after him, called the Goldberg staging system. We just passed 50th anniversary of Goldberg staging. So I wrote an editorial that you should check out as well that basically speaks to my admiration for them. All right, so that's one of my highlights of career too. So 1945 is how do I know that the eclipse took place? Well, buried in this article is a beautiful photo, which is absolutely amazing. And so here's Mark Goldberg on a train from Tokyo to Kyoto in the late 1970s. There's a really charismatic looking guy sitting next to him that we'll get back to. And then there are a few legends of the field, like Steve Ryan is sitting right behind. Christina mentioned that I was the Stephen J. Ryan Professor, which is the endowed professorship for the chief here at Hopkins. And the legendary book of ophthalmology for retina is called Ryan's Retina. So that's Steve Ryan right behind him. And there are a few other legends right behind him, including Paul Kenheim, who's chair in New York, and Paul Wetzig, who's in Colorado, and E.D. Norton at Bascom, and Arnold Patz. And if you go to Hopkins and sit in the auditorium, you sit in Pat's auditorium. And maybe there's some random other person in the room. So who is this person sitting next to Dr. Goldberg? And how are we all connected, basically? Well, this person is the young man that you see in this photograph with all this like perfectly arranged, self-portrait that he took. Yeah, different than the current modern era. So. Okay, so this doctor is a very famous doctor, Gerhard, known as Gerhard Myers-Fickervath. I don't really speak German, so sometimes I'll just refer to him as Gerhard going forward. So really amazing guy. I feel amazingly privileged to be connected to him in a couple generations, but he was born in the 1920s, so we're talking about a long time ago, 100 years back. And he is from a family of lawyers, chose medicine even in the face of rising Nazism. And he served as paramedic in World War II in Germany. He then became a physician at Hamburg-Eppendorf. His mentor was Professor Marchesani, which is a very famous name in ophthalmology. And then he later served as chair at Essen University that I'll show you later. So I'm sorry, it's so laggy. Dr. Svickervath is best known for inventing laser photocoagulation. So this is how it's relevant to the photograph of the patient. I'm seeing a patient in clinic yesterday who's had vision saved due to this guy born in the 1920s. And it's a pretty amazing story because if you go look at some of his personal accounts, he was 25 years old when he came up with this idea. Basically, he had seen patients with uh, burned retinas, in other words, solar retinopathy from this eclipse in 1945. And at 25 years old, had this epiphany that came to him in the middle of the night that he had to wake up and write down and pursue, that you could take the energy from the sun and direct it to the retina and actually treat retinal diseases. So that became the purpose, the thesis that he later wrote with Dr. Marshashani. So the first thing that he did was take a carbon arc light source to put together a few lenses and mirrors together, and basically went to his mentor to try to prove that he had made some burns. And his mentor didn't even believe that he actually had created some burns. He thought he had switched the animals around, which is kind of comical there. And then after trying a few more times, he was able to realize that he could actually get a exposure times to provide localized burns there. And then he then developed a series of lenses that were able to focus the sun as a light source. So I'll show you this apparatus here, but this is his original sunlight photocoagulator from 1947, which had a series of different lenses to them, mirrors and diaphragms, and actually had a direct ophthalmoscope as a delivery mechanism. And here's Dr. Myers-Vickervath delivering this to a patient. Basically, you had to stand on the roof and have the patients actually call you. So it was pretty comical. He actually stationed a patient on the roof as the clouds went by. And then once the sun came up, he'd have them buzz down to the clinic and he'd run upstairs and actually treat their retinas. So the funny thing was the dependence on the weather was really, really annoying. And he actually was so annoyed that he put it in the writing that he was annoyed by this. So I don't know where Essen, Germany is. So I have to look this up on Google. And if you look in Essen, Germany, it's actually up in the northwest corner, right by the Netherlands. And if you're curious, the weather is not good in Germany. In fact, it rains a lot over there. This was just a random query of a week of weather in Essen, and it happened to say rain every single day. So the funny part was then he had to basically find another light source to be able to generate artificial light to treat the retina. And originally was the carbon arc, which is what you see here. The arc intensity is greater than that of what we see at the sun. And here's some example figures from his book where he basically took this carbon arc light to treat tumors and retinal tears. I'm sorry, it's so laggy. So in Dr. Goldberg's article, he highlights this as one of the greatest innovations in ophthalmology. Thanks to a solar eclipse in 1945, he had this epiphany, and he later wrote this book called Light Coagulation. You all should go look it up. It's really interesting. I have a first edition copy in my office. I let the residents borrow it because it's just amazing to read the initial accounts. But one of the things that happened after the solar coagulator worked is that there's another German company, the Zeiss company, that's still around. They actually had a xenon arc photocoagulator. And as Dr. Goldberg likes to say, this thing was like the size of an ugly Jeep. It was very practical, but it took up like a whole room, but at least it could provide an artificial light source to be able to direct light and treat the retina, as you see here. So. And then the argon green laser eventually came out. And part of the reason that we use the argon green laser instead of other things like the carbon arc and xenon arc laser is simply because of ergonomics. The argon green laser could be delivered by slit lamp. So if you can imagine, instead of being with a direct ophthalmoscope right up against a person's face with like gigantic burns, you could more elegantly deliver it by slit lamp. And fast forward essentially 60 years later from the 1960s to now, that's still what we're using in the clinic. All right. Sorry, it's so laggy. And I just want to point out, like Dr. Goldberg highlights in the book that the treatment of the time for diabetes, including some things that we would think are completely crazy these days, But one of the treatments for diabetes was pituitary ablation. And here's an example of pituitary ablation. You literally go stick a scoop up somebody's nose and like scoop out the pituitary in hopes that the diabetes would get better. So you fast forward a couple generations and we've come a long way in medicine. So, all right. Uh, the part of the story Dr. Goldberg comes in with laser is actually only in 1968. So one of the earliest clinical trials in all of medicine is the diabetic retinopathy study. And this came in the 1960s when diabetes was essentially an epidemic. People were going blind. We didn't really know why. And then there are a lot of motivated doctors on the East Coast that essentially decided to start a initial meeting to bring together experts across the country/world to discuss diabetes. And this was Stuart Fine and Mort Goldberg, Stuart Fine that you see here over on the right. And they actually wrote this entire 900-page symposium just from this 3-day event, which became the landmark initial book on treatment of diabetic retinopathy. And they chose this beautiful Airlie House in Northern Virginia, which you can still visit today, actually. This like, I guess it's like Rococo style or something. But just to show you where it is on the map, here's Baltimore, here's Washington, and Airlie House is over just to the west. Over here, it's a very picturesque retreat. So essentially, the Goldberg and colleagues organized this meeting to sit down and hash out everything they knew about diabetes at the time, put it all on a table, and talk to everybody and say, what are the different aspects of diabetes that we should pay attention to? What are the different stages of diabetes that we pay attention to? And they designed 2 large clinical experiments that paved the way for the first large clinical trials, the diabetic retinopathy study and the early treatment of diabetic retinopathy study. And those were the earliest clinical trials in ophthalmology that demonstrated the efficacy of laser. So here's a DRS laser. And laser basically took the risk of severe vision loss from proliferative diabetic retinopathy, which is like 50% in a year. You would go blind and be sitting in a corner, and reduce that by 50%. And that may not seem very impressive to you folks today, but there's no anti-VEGF injections, there's no vitrectomy or anything. You get one bleed, you're done. You can't get laser, you can't get anything. You get a second bleed in the other eye, and suddenly you're sitting in a corner with inability to see. And the patients who are affected are still about the same age as the ones today. They're working age population folks who don't have an ability to have a living as a result. So basically, once this study came out, it was a first instance of evidence-based medicine, and it's an example of where you can take crazy stuff, quite frankly, like scooping out the pituitary, and support it with really well thought out ideas that are tested through randomized control clinical trials. So really, that's the story of an eclipse, 1945, like 80 years ago, informs a solar coagulator. You take an artificial light source like the carbon arc and the xenon coagulator. Then there's later advances in imaging that help us detect diabetes and understand it better. Airlie House happened in 1968, DRS 1972, ETDRS 1979, and then all the way till today, till now, we still use the laser treatment that's there to treat patients with diabetes. So the patient I saw yesterday has that a laser that had been done 30 years ago, was told that he was going to go blind by the time he was like 20. And now in his 60s, he's still seeing really, really well in both eyes. And that's thanks to Dr. Myers-Vickerbath and then Mort Goldberg's in between 1960s. And then Goldberg was one of my mentors actually in residency and fellowship. So he spanned like 80 years with 2 generations in medicine. Is really quite cool. All right. So that's that. Oh, I sent an email to Dr. Svickerath when I was presenting that at Grand Rounds at Iowa, and he just wanted to share all these great words about Dr. Svickerath and how kind that he was. And essentially, this is my favorite part of the story. He even asked that children call him by his first name. In fact, Stuart Fine hosted this nice party at his house in the 1970s, and this very charismatic German doctor just asked him all about things he didn't understand, like American football and baseball. And so this is a friendship-based business that we're in. So All right, so we're basically all on the train with Dr. Sikravath here. So that's basically you guys here, even on the Zoom today, traveling with him. So- All right, I don't know if I'll do the next story, Nick. What do you think? We've got 30 minutes. I can do it in 15 minutes if you like, or we can do Q&A because there are a lot of people, and I just want to make sure that people have uh, a chance to ask questions and engage in however they want to. What do you think?
I think we can go for the story. We can take a couple extra minutes at the end if we have, more questions we want to fit
Okay.
in. It's all right
Yeah,
if we
well,
just roll over.
forgive the lagginess. I apologize about the animations. It's tougher on Zoom too. But let me tell story number two in brief, and then I like story number two because it goes from a historical story from the first patient that I just showed, where we've had an anchor of treatment for like 60 years, to a more mystery diagnosis that we've been working on, and some of the mentors that I've had that goes through there. So I'll kind of buzz through this, but there's many things that you can learn if you kind of pay attention out there. And similarly on this timeline, I'll share various stories along the way to where we were. But again, last week I saw a patient with mystery diagnosis. All right. So this fundus looks, for all intents and purposes, entirely normal. There are a few little mild pigmentary changes, but the optic nerve, vasculature, retina looks pretty daggone good. And if you go look, this is a 60-year-old guy who has intense photophobia, has painless progressive vision loss, and the local diagnoses have told him he's basically a malingerer. You're totally faking it. You're totally making things up. There's no diagnosis. So he labeled him as an unexplained vision loss patient and sent him in. And the initial photo 7 years ago, he had good vision 20/30, but this is the left eye. And then if you look at his OCT imaging, it looks pretty good. The retinal laminations all seem to be there. And the photoreceptor band is this white band out in the retina. And that all looks pretty good for both eyes. And this is called a goldmine visual fields that shows you basically different intensities of light and has a patient kind of tap out what they see. And his visual fields are pretty good, but he's got a central blind spot. That's what that red dot demonstrates. And then in order to demonstrate that this guy's not faking it, we hooked up a lot of electrodes basically around his eyes. This is called an electroretinogram. And essentially what this thing does is you can flash various intensities of lights to the eye itself and to the retina to stimulate it. And then you can then measure the retina's reaction to different intensities of light to demonstrate whether there's functional loss on top of structural loss. So it's an amazing field that we're in ophthalmology to be able to see parts of the retina. There's a very strong correlation between structure and function. But if the structure looks good, there may be an issue with function. And this is kind of what the ERG shows. And basically what you're looking for is if it's normal, it's in the box basically. And this ERG demonstrates that his cone function, photoreceptor function for central vision is not normal. So he's not faking it, in other words. This is a multifocal ERG that maps out the cone responses specifically. You're supposed to see waveforms that look like this, but right in the middle of the vision where it counts, he's not getting the right waveforms. So he's not faking it. He has some mystery vision loss. And he's not only that, but as we don't know what's going on, he's losing vision before our eyes, and nobody knows why. So here we go, 20/30, 2100, 20/60 over a 2-year time span. As a working age guy, obviously not very happy. So why is he losing vision? Well, this is kind of part one of this second story, and it's kind of the back part of this, and it has to do with the imaging itself. So this is my good friend and mentor is Glenn Jaffe. He's the director at Retina at Duke. He's a legend in the field in his own right, and he was the research mentor for me back when I was in medical school. So I'd just like to point out this is me back in medical school with him way back in the early 2000s. And then this is us just last year. He hasn't aged at all, whereas I've gained a lot of white hairs along the way. So how I got to Glenn was actually having a really good mentor in medical school who is an MD cardiologist. I just happened to be interested in science and research when I was an undergraduate. My dad's a computer science professor, just retired last year, taught for almost 40 years. And I wanted to do science. So when I was an undergraduate at Duke, I found a biology research lab that was really cool. It was this guy, Chris Contos, had a reputation on campus for being a great mentor, but he's an MD. And then when I was in his lab, he essentially told me one day that I should go into medicine. And I asked him why, and he said, most real biology research for good applications these days has biomedical applications. And going to medical school is a really, really good way to build a foundation of understanding to understand that level of research. So without knowing much about medicine at all, in fact, I had hardly shadowed in the clinic or the OR. I applied to medicine based on this guy's recommendation. And then what I was working on at the time was actually unknown receptors, including this Thai-angiopoietin pathway. Those were orphan receptors at the time, and it's kind of full circle, but the latest drug for macular degeneration, for example, that you see on TV these days is a bispecific medication. The generic name is faricimab, and it binds vascular endothelial growth factor and the Thai receptor. So it took 20 years to kind of get to the clinic. And then these were my first papers that I wrote. They were kind of survival factors over in Jaffe lab, because when I got to medical school, I asked the same senior residents, the same senior medical students, the same things, like who's a good mentor on campus. And they said this guy who runs a really interesting retina lab. And I actually took on Jaffe lab because I was intimidated by the cardiology labs at Duke with Nobel laureates and others. And so I asked Dr. Jaffe what I should be researching and what I should do with my life. He said, if you understand blood vessels, you understand the body. And if you do blood vessel research with me, even if you want to do cardiology, surgery, whatever you want to do, then you can match in whatever you want. And so I trusted him on that and wrote a couple papers with him. They happen to be on different cell survival factors in animal models. But what was really cool is even though I signed on to do a basic lab research here and had no real interest in ophthalmology, he happened to come over to me and say, hey, you know, I have some interesting new instruments in clinic. I run a reading center here for clinical trials. And so why don't you come check those out? I think you might be able to have a cool side project. Come up to the clinic nights and weekends. So he walked me up to the clinic as part of the Duke Reading Center. And there's some shiny new instruments there that were prototypes at the time, so that kind of dates me, but these are called optical coherence tomography instruments, and specifically these are spectral domain instruments. These are the ones that we still use in clinic today, and these were all prototypes. They weren't out in commercially. So OCT, hopefully everyone on the call has heard of, but it's an amazing thing that we get to use in medicine. From the early 1990s, Dave Wong, Jim Fujimoto published a landmark paper about how you could basically use a coherent light source to reflect off the different structures in the retina, take that back to a careful sensor, and be able to construct a three-dimensional kind of in vivo slicing through the retina. And this is from their original 1991 paper. You can see how crude that image is, but actually it's incredible because you get some contour and topography without even entering the eye, if you will, except with a light beam. So this is the histology of a normal retina. It's just absolutely stunning. I don't know if you can go through medical school without, I'm kind of biased as a retina surgeon now, but I don't know if you can go through medical school and not think that it's the most delicate part of the body with this level of organization. But even more amazing is you can take a light beam and reflect off these layers and recapitulate that anatomy. So this was the original first commercialized OCT back in the early 2000s. It was time domain OCT. And this may not look very impressive to you. Maybe it's like Atari era or something, but you can actually see into the retina and detect whether there's swelling or not, as an example, with that level of technology. It's totally game changing. And then when spectral domain came out, it was made more efficient by basically using a more sophisticated sensor and kicking out a reference mirror. So the original coherent OCT had a original light source that had to go to a beam splitter. And the way that it knew where the signal was coming back is it would send half of the beam over to a mirror, and the mirror would rock back and forth to kind of set the distance. And then it would be able to calibrate that distance to where the tissue was reflecting off of. But with the magic of more advanced sensors and computational power, you could basically take the spectral pattern off of the retina reflections, hence the spectral domain aspect of the description, with sophisticated math like Fourier transform, and recapitulate the signal coming back there, thereby making the signal's strength, quality, resolution a lot better, and the acquisition a lot faster. So that was the innovation here. And it basically turned this image into this image, which is just night and day difference. So this is the image that you guys, if you're in the ophthalmology clinic, are pretty familiar with. But that was a new thing at the time. We had never really seen that. That's when I was starting in as a medical student. So we actually didn't even know what all these bands were. We had never seen them before. So my initial project was kind of silly, but Dr. Jaffe just had me set out and kind of compare these bands to histology, measure the different thicknesses that the software was spitting out, and compare that to what we knew from the original technology. So we had to actually go help and define these bands in relation to histologic images. And those were the first couple papers that I wrote in ophthalmology with him. They were simple comparisons of different thickness measurements and how the software could go wrong. And this seems like a nothing kind of thing, but if you're in the right place in the right time, you trust a person who has access to some of the cool stuff, and you do the work. These papers, I'm happy to say, have been used in darn near every clinical trial that used OCT since then, because it is a reference paper for retinal thickness and the different measurements that you get from some of the commercially available instruments. So here's one of the initial figures in the paper where you can compare the time domain to some of the other instruments that we had. And one of the important things we realized is because the companies didn't know which line was what, they actually decided software-wise to put the line on a different structure of the retina. And so clinical trials had to take into account for this, the differences in thicknesses if you're going to measure and follow a patient over the course of time. So here's the OCT of normal retina. This is an amazing thing about ophthalmology. We've since defined these layers really, really well. And that's basically spectral domain. But going back to the patient that we had, I think most of what are in clinical ophthalmology, we are still in a time domain level of interpretation, meaning all these bands in a clinical perspective, we may or may not be paying attention to a whole lot in detail. So enter part 2 of this story. When I started my career as a official faculty member, if you will, I was wondering what were aspects of research that I could pursue, a niche that I could build, and what aspect of my training I could kind of leverage for the next generation. Those are all the questions that you kind of ask in your early stage career. And I think you just have to keep your brain turned on, because there's lots of different things that come right in front of you. And that's this part of the story. So this is a nasty eyeball. This is a patient with an infection in the eyes called endophthalmitis. And I kind of tongue-in-cheek call this epiphanous endophthalmitis, because this is a patient I was just seeing routinely in the clinic with a post-injection endophthalmitis who had an eye infection, needed treatment. And an awesome fellow at the time, this guy named Sam Bossi, is a retina surgeon out in California, who was a diligent fellow. And Sam basically took a sample from the eye, injected antibiotics as the fellow, and told me something that should not happen, which is that the sample was already growing staph epi. If you've ever done micro, you actually know you put out these plates and stuff, and you have bacteria grow, then you do all these little tests to speciate the bacteria. So I was very skeptical and said, Sam, how do you know that the next day this is a weak bug, staph epi? And so it's trust but verify. And actually never trust anything on me. And then how could the positive be culture, culture be positive already? And he basically said, well, there's this thing in the system called MALDI, which I'd never heard of at the time. It's brand new. And essentially what that does is what you usually do is you take these identification protocols through these plates, but there's a rapid identification protocol where you can essentially take bacteria that's growing, split it into smithereens, and then take mass spectrometry to and analyze the bacteria. And how it actually does that is by taking these bacteria and then splitting up and analyzing the ribosomal pattern, because there are different ribosomal patterns for different bacteria subtypes. So that's when the epiphany came to me, and we're just sitting in clinic and saying, oh, wow, we've got all these different layers. What could we do with all these layers? What if we actually sub-segmented all these retinal layers and analyzed them more agnostically than qualitatively? So hence became a different type of project. And this is one of my good friends and colleagues at the university is Mike Abramoff. He's leading the world in AI applications for retina care. So he pioneered the first ever FDA-approved AI diagnostic telemedicine screening for diabetic retinopathy, for example. And Mike had developed a way to use algorithms to segment the retina very reliably. So when talking to Mike, I borrowed his algorithm, open source, threw it on the retinas. And lo and behold, you could analyze a lot of stuff like that. You can analyze thinning and sickle cell, Stargardt disease, make a lot of inferences. So I'll skip this part. So enter this guy. This guy is Ed Stone, who's a legend in our field. He's the guy who recruited me to the University of Iowa. And he essentially founded the field of genetic ophthalmology or molecular ophthalmology. So he's geneticist, PhD by training, and mapped some of the earliest genes in ophthalmology, and is the director of the Institute of Vision Research that I work in. But even in his kind of senior status with a lot of experience, he asked me as a junior faculty member, said, "Hey, can I get input on this case?" And it's the case I was showing you. He's like, "There's this guy, we're losing vision. I'm totally stumped. I'm totally stumped. I did what I know how to do. I rummaged through the entire DNA and we found nothing. I think it's got to be genetic disease, but there's this wastebasket category where the immune system might be reactive. It's probably not genetic. There's nothing else that explains it. What do you think?" basically. And he's like, "I've determined that every case I don't know basically is autoimmune retinopathy. It seems to be kicking our butts right now." So he kind of reached out to me in desperation for help. And that was the case I was showing you. So even in my first year as faculty member, I said, "Well, Dr. Stone, this reminds me of the craziest case I've ever seen in my whole career. I'll tell it casually and brief. I had this guy. We published it right here. But this guy was 40 years old, and he was losing vision just the same way. He actually had a central scotoma just like your patient. The retina looked entirely bland, except the optic nerves may be a little bit pale. The vision loss was bilateral sequential, so we thought maybe it's an optic nerve problem, this bizarre thing called Leber hereditary optic neuropathy. I talked to this guy, neuro-ophthalmologist at our institution, Dr. Thurtell. I call him Sherlock. He figures everything out. And Dr. Thurtell basically said, "Well, I'm not sure that it's Leber hereditary optic neuropathy, so let's get an MRI." And once we got an MRI, it showed these non-specific optic nerve enhancements. So we're like, "Oh, maybe this is MS, maybe this is neuromyelitis optica." So diagnosis number 2. But then when they did the MRI, they found the creatinine was high. So when they did the additional workup on the kidneys, they found a giant Goomba on his kidney with this exophytic growth on the thing. So next thing you know, they're talking about renal cell carcinoma. And they did an ultrasound Gaia biopsy of this thing. And when they took the biopsy over the lab, it actually didn't show renal cell carcinoma. Or in diagnosis number 4, they actually showed a renal oncocytoma, this rare tumor. And the PET-CT was consistent with oncocytoma with no other lesions elsewhere in the body. This huge thing right here is 8 centimeters. So we took it to a tumor board. We said, there's this case. We've got this big Goomba. It's a benign lesion in the kidney. It's not causing any other problem other than elevating his creatinine, but maybe there's some other reason to resect it. And they said, "No, there's no reason to. It's totally benign." But I wasn't comfortable with this. I was convinced that vision loss was related because the dude's otherwise healthy 40-year-old. So I went down this rabbit hole for perineoplastic response to oncocytoma and found that the patient actually on a serology had autoimmune retinal antibodies to enolase, hence providing a putative link. Okay, maybe the tumor is expressing enolase. It's pissing off the immune system, excuse my language, and then maybe that's how it's attacking the eyes. So went to pathology, asked for the oncocytoma specimens, took it to our pathologist and said, "Hey, can you stain for enolase? And we're going to solve this whole mystery." And the pathology fellow said, "Sure, we can do that," and called me and said the thing was entirely negative. So I don't know what sort of totally bonkers idea that you had. It's totally wrong. But kind of like Dr. Stickervath, I couldn't sleep. I was actually very disturbed. I signed this guy's paperwork. I didn't feel bad. I didn't feel good about it because he basically had gone blind before his eyes, and his vision had declined from seeing a little bit to basically count fingers level vision. And he met legally blind criteria. So I couldn't get over the case, went down another rabbit hole, looked up enolase instead of oncocytoma, and then turns out our pathology lab only had gamma enolase. So it's a different kilodalton size than what we had on the retinal antibody. So coming to the tail end of the story, let's go look at the path again. But there's a guy in the lab, Rob Mullins, who's the world's best histopath guy in retina. And I basically went to Rob and said, "Hey, do you have any alpha enolase antibodies?" He said he did. So I went and got the specimen, took it over to him. He stained the specimen, which is the oncocytoma specimen. And it basically lit up all the way around with alpha enolase on stain. And I basically asked Rob, and it's like, dude, I think this is pretty convincing. Let's take it back to the tumor board. So I took it back to the tumor board, and they said, nope, not resecting this tumor whatsoever. Why listen to the ophthalmologist? How could this goomba in the kidney actually be causing vision loss? And I still wasn't feeling good about this. So on top of that, sinus disability from temporary to permanent in between. So the last part of this, still couldn't get over the case. I actually decided to email an oncologist directly, our top urologist, urologic oncologist at Iowa, this guy named Matt Nepple, and Ken Nepple. I basically told Ken the whole story, and he was on the tumor board, and he was like, you know what, everything you're saying makes sense that this could be the cause. I think we should go do it because I'm not worried about his kidneys. I'm worried about his eyes. So let's go ahead and whack the tumor and see what happens. So he ended up deciding to take down this tumor as it is. Sorry, it's so laggy. And it was miraculous. Eventually, the patient's vision got better after we did this. So we totally wrote this up where there's this autoretinal antibody, paraneoplastic, benign tumor, distal effect. And he's to this day the first patient that I've ever taken off permanent disability because he went from count fingers to, believe it or not, 20/20 within the year. So this is a joke about a fellow who always says everyone's 20/20. So how do we actually solve autoimmune retinopathy? Well, I had a really eager fellow who wanted to take on this project, this Chris Fordenbach's faculty over at Washington. And he said, hey, I'm one of the new interns. My friend knows you. I want to work on something like autoimmune retinopathy. And I said, no way, this is the most mungy field that I don't want to touch. But then I thought about my mentor, Dr. Stone, who really need help. Said, fine, we'll take this on. And so we outlined a research plan that kind of dovetails with the whole pathway of what you've seen. Basically, we take autoimmune retinopathy patients with all different antibodies. They should correspond to different retinal layers. If we take this malady concept and blow the retina into smithereens and isolate the different retinal layers for analysis and do semi-automated AI-based analysis, maybe we can associate with these with various autoretinal antibodies, and we can solve it, and I can take a junior faculty like Dr. Boyce has shown here to be the champion of this instead of me. So this is actually what we did. We published this paper on this just a couple of years ago and demonstrated that you could actually take these different subretinal layers and identify different phenotypes based on the different layer patterns that are there. And in fact, the interesting thing that we found is that we couldn't find a specific association between antibody and retinal layers, but there's a specific subset of patients for one specific layer called the outer plexiform layer that instead of suffering damage and getting thinner, paradoxically thickened. It was a paradoxic thickening, and we had a bunch of patients that actually followed this. Some had this kind of sawtooth pattern. Some actually had this split appearance. So, which is what you see here. So the last part of the story, kind of putting things full circle, is the patient that Dr. Stone had me take a look at who was losing vision was a maligner, called a malinger, but actually had functional evidence of vision loss on ERG, had this very, very subtle phenotype, which is this little thing right here. In other words, there's supposed to be a band of the outer plexiform layer, and it just very subtly splits. And I told Dr. Stone this and said, hey, we identified this basically with breaking the retinas to smithereens with AI and other things. Does he have any tumors? And he said, yes, actually, he has this benign hemangioma in his liver. It's several centimeters big. Nobody wants to resect it. But if you think this is convincing enough, you go talk to the surgeon and then see if you can convince him to do it. So I called up his surgeon in Illinois and told him this story. Good vision, decline within a couple of years. He has this huge hepatic hemangioma. We looked all over the place and there's absolutely nothing. Had this other case with a benign renal oncocytoma. And after the resection, his tumor improved. Why don't you go take out his tumor? So that surgeon actually decided that was good move. We took it out and his vision improved. So this full circle thing means even back from medical school, you can take OCT-based imaging and basically solve a modern problem with taking on all these different technologies, engaging in some of the trainees and mentors who are with you to go tackle a problem, champion the patient's case despite all these different barriers. And then once you get to that, you find something that nobody's ever known about before. And that's the beauty of medicine. You can actually save vision that way. All right, so I'll skip all this stuff. It's too granular. So that's that. So that's story number 2. I'll go back to this slide just as the Q&A section gets on here. But basically, medicine's awesome. You know, every day is a new opportunity. Just emphasize for those who join later. And then I've shared a couple people that I interact with who are mentors of mine who are very wise, who are willing kind of engage in medicine for all that it is. And then these relationships are personal stories that I like to share because far more than any specific experiments, the relationships are what make the journey very fruitful. And then if you can keep your brain turned on, even like an endophthalmitis in the clinic will inspire some other new way of thinking about analysis. And then what I found is some people, even in their hobbies, like Mort Goldberg for sickle cell retinopathy, coined a term that is very famous called C-fan retinopathy. And he determined C-fans based on his passion for scuba diving and seeing corals on a continental shelf. So if you actually have hobbies and family and work all synergize, you never really work a day in your life because you come in for fun. And then also when you're taking time off, you're also informing your work. It's pretty nice like that. And focus on building some relationships in your journey and share some of your journey with others. So that's a 2-story ramble, Nick. I hope some of that came across. Sorry for the lagginess on the presentations. But I'm happy to answer any questions, probably less about the stories and more about whatever you guys want to know. So.
Well, thank you so much, Dr. Han. A couple of really amazing stories and some awesome takeaways on just the journey of medicine as a whole. We will go ahead and get started with our Q&A portion. Since we have a lot of folks in the call today, we'll do the way we usually do it, which is with the raise hands feature. So if you see at the bottom of your Zoom, you have a reactions tab and there's a little raise hands button there. If you have a question, click that and I'll call out your name just kind of in the order that I see them. And then you can come on and ask your question to Dr. Han directly. We also have a couple of pre-submitted questions, which we can get to at the end, but we'll save time for the in-person questions first. So if anyone has those, feel free to raise your hand. And I see Vincent has a question already. So Vincent, you want to go ahead and kick us off?
Hey, Dr. Han, I'm Vincent, researcher at UCSD. So one of my mentors here is really big on ocular oncology. So one of my questions for you is like, what is the future for ocular oncology and the overlay between retina and ocular oncology? Because it seems that those two go really hand in hand, you know, with macula, background, vessels, all that stuff.
Yeah, no, hey, Vincent, thanks for the question. Thanks for tuning in. I think oncology is amazing. And in fact, I work with 2 really amazing ocular oncologists who are also vitreoretinal surgeons, Elaine Binkley and Culver Bolt. So I'm incredibly biased on this channel because I see how gifted they are, both as retina surgeons, but also as tumor doctors. But I think maybe just honing in on a theme, everything kind of ties together. So my story from the cardiology lab to the retina clinic is shared through blood vessels as an example. So one example is it's a living human being has living blood vessels. If you understand blood vessels through the body, as Dr. Jaffe told me, you understand how anatomy really works. And I say this to my own trainees so much that they call it the hand of Han. But the way that I have 5 fingers I gesture at, we spend most of our time in medical school learning pathophysiology, you know, the stuff that really screws us up. And so I use that as the middle finger, if you will. And then the rest of the time in treatment. And it's pretty powerful. Like if you bind those 2 things together for whatever the diseases that are, geez, there's so much to know in medicine, but you're pretty powerful. You can practice pretty effectively that way. Pathophysi, you know, disease and treatment. And I like to call the pinky evidence-based medicine because it's a little bit less robust than the other parts. And it's really, really important, but it's kind of the supportive aspect of the hand. So what are the thumb and index finger? The thumb is actually anatomy, embryology, anatomy, and physiology. Like if you understand anatomy, i.e. blood vessels, and you understand physiology and how it all works, you can predict pathophysiology. So actually things should go this way, not this way, studying the disease back to the anatomy. You should think about anatomy, then physiology, then pathophysiology. And it seems kind of crazy, but then if you know pathophysiology, you are not surprised at all about treatments. The treatments totally make sense because you can imagine how things go wrong. And if you know exactly how it goes wrong, you can imagine how to fix it. And then the last part's even crazier because you find a lot of big pinky people, as I call them, who like kind of flail around evidence everywhere. And evidence is really important, but it kind of comes supportively last. If evidence violates anatomy and physiology, you shouldn't really believe that. So these things should all go in this direction if that makes sense. So the roundabout answer to your question is like, you can do whatever you want. Retina, oncology, it's all awesome. Everything ties together. Those two things go really, really well. And there's a lot of innovation in ocular oncology as it is, because there's so many shared important pathways. Case in point for us very famously is that, you know, Avastin is bevacizumab is a colon cancer drug. Colon cancer requires recruitment of a lot of blood vessels. And if you're very pioneering, you realize that abnormal blood vessel growth in the eye can be treated with the same anti-vascular endothelial growth factor as for colon cancer. So that's one of the more famous examples.
Thanks, Dr. Hahn.
All right, Bridger, the floor is yours.
Thank you. Thanks, Dr. Hahn, for that talk. I'm a third-year medical student at Case Western here in Cleveland, and starting to get ready for application season and things like that. I've done a lot of research in basic science lab with Dr. Ree, looking at mice models for glaucoma.
Sure.
And I think that's something that I want to continue, you know, at least maybe not in that same setting, but in, you know, make that research a part of my training going forward. So my question is, how would you recommend sort of assessing that as a fit when looking at residency programs and seeing how they support that idea during interview season and things?
Yeah, it's an absolutely great question. I think if you have background in research, that's fantastic. You can do anything in medicine. And I'm biased, but ophthalmology leads the world in a lot of stuff. You know, gene therapy, stem cell therapy, first clinical trials for diabetes, for example. So if you step into ophthalmology specifically, having a science and research background is very powerful. I shared that I wanted to be a PhD scientist, got talked into medicine. And then when I got into medicine, I want to be a cardiologist. I got talked into ophthalmology by mentors that I trust. And then when I got to residency, I didn't intend to go to Hopkins. I thought it was too intense. But Dr. Jaffe told me to go there because he thought I had the mind for academia. And then when I got to residency, I asked some of the mentors there what I should be focusing on. And interestingly, they didn't tell me not to do research, but they told me to focus on being a really, really good doctor. And in hindsight, it's been a number of years, but in hindsight, I kind of thought about that. I don't know if they saw that I already had the ability or the experience to do science, or whether they didn't want me to do science, or whether they thought that there was just too much to learn in ophthalmology residency. But having lived through a very rigorous training, like before work hours was a thing, and it was like 110 hours and stuff some weeks at Hopkins, there was so much to know. And so the shared theme then is every day is precious and it's a new opportunity, but time is by far your scarcest resource. And then the yin and yang of it is that your greatest strength is your greatest weakness. So if you bring strength with research already, then that's a lot of time investment in that already that you don't necessarily have to build. Your back-end weakness might actually be clinical understanding. So for example, I had an MD, PhD hotshot. I mean, he's awesome, really smart, who was a resident a few years ago. And he came in day one and said, hey, I heard you're a good mentor and you research that I'm interested in. Can I do research with you? And I basically looked at his CV, talked with him on his background a little bit, and I said, you don't need to do a drop more research into your residency training. You have this much time to learn. It's a little bit like doing bicep curls only all day. You know, your biceps might be really big, but you can't skip leg day, because if you skip leg day, there's no way you can put together this thing that I just described with renal oncocytoma all the way to like how the retina is impacted. There's just no way that you can do that. And that's very powerful if you can. So anyway, long way to answer your question. I think residencies will treat research differently, and they'll provide different amounts of time to it. I think that can be very appealing if they offer research time, because it seems very valuable. But on the other hand, you have very limited time. So it's a positive thing if the program offers research time, because that means they value academic pursuit and thought and innovation and stuff like that. But it's a dicey thing, in my opinion, if they offer a lot of time, because then what else aren't you doing? So for example, like we make decisions as humans in very simplistic ways sometimes. It's sometimes binary decision making distilled to its essence. And I found that when I was going through residency interviews, I didn't understand anything. So a lot of my colleagues were just asking about the number of cataract surgeries programs did. And it basically was linear, right? Like the more cataract surgeries that you did, the better the program might be, at least conceptually or simply. But I kind of thought about it and it was like, you know, yeah, there's all this to learn. If you do 1 million cataracts, what are you not doing during that time? And similarly, in a weird way, like OCAP scores or some testing scores, if a program had really high scores, that's obviously a sense of pride. They have good people, really smart, they study well, they have good educational program. But if what you're doing is studying some of the quote unquote obscurity for these tests that aren't as directly important, like, is that really speaking to the strength of the program, or is that because providing you free time out of the clinic to go study? Like every day, every time that you have freshes, and that's what we weigh for opportunity cost of every decision for the rest of our lives. Like if you have a strong research background, it informs what you do, but you don't necessarily have to do lab research in residency. In fact, I did zero. I published 0 papers in residency. So it's a badge of pride now, but maybe it was embarrassing then.
Thank you.
Maybe I'll throw out one of our pre-submitted questions, since I think it kind of connects to some of the stuff you're talking about, Dr. Hahn. How did you go about in your career finding a balance between, you know, patient-facing time versus, you know, dedicated protected research time? Since you were kind of saying, you know, the two kind of inspire each other and they go hand in hand.
Yeah, I don't know. I made a comment at the very beginning that things like work-life balance or multitasking, these type of things are a bit of a fallacy. In a way, you are who you are, and your identity is defined by things that you'll take hold of. So I became an ophthalmologist, and one of the first teachers that I had at Hopkins wouldn't let me go with an I don't know answer to a question he was asking, because he's like, you are an ophthalmologist now, you have to know, as Mark Cho at Hopkins. So I took that on as an identity to say, this is who I am, this is what I am now. How can I be that in the times that are really important in a way that's reflected for patient care? But it's not like when I leave work, I'm not an ophthalmologist anymore, or I am a researcher. And, you know, you just have to keep your brain turned on. That being said, there are a bunch of fallacies out there. I think multitasking is a concept that I don't necessarily subscribe to, because it connotes that you do many things at once. Whereas I think that's a very ineffective, distractive way to do things in our fragmented world. In reality, you can run many things in parallel, but you have to be fully present when you're doing that other thing. It's just that hopefully you can synergize a lot of stuff in the clinic to the lab, as an example. So I actually start by, there's a lot I could say about time management, but I actually start with an admiration of the dynamicity of medicine. It's so beautiful because it's this intimate patient relationship that you have. You can really meet patients where they are. And I'm very casual with patients. I just come in and say, you know, tell me about something interesting. You know, it's like what's going on in your world is an entryway when I come in their room, because I just want to sit in their space a little bit. And then when you do that, ideally you just engage in a patient right there to understand their context, because the decision making of medicine should eventually slow down with more and more knowledge. And then once you can understand context, you can start to synergize all these specific aspects of medicine that inform decision making and your research. And then our partition time then starts with individuals and relationships. So instead of prioritizing projects, I actually have this like nested electron cloud shell of people that are really important to me that I work with. And those include some of these mentors and legends of the field who you would think maybe don't have time for you, but they actually crave this opportunity to guide a brilliant person to the next stage of their career. So somebody like Ed Stone, who's a legend, but he's like, you know, like 30 years older than me. And he's a colleague of mine. And technically I supervise him on this retina surface now, but he's got 30 years more experience than I do. And he's a busy, busy guy. I basically say, Ed, I need at least 30 minutes of your time every week. And we just anchor it down in that time. And we hone that time to talk science and stuff. And then I have a host of people that every single week I'm meeting with on time and in rhythm, because then it sharpens the conversation. It builds our mindset and culture together. It keeps forward momentum going with various projects. And then I schedule my whole day based on those people. And then the projects and everything kind of falls together. And then the time you're in the clinic, you're in the clinic. The times you're in the lab, you're in the lab. If you focus on the people, the projects come along too. And then it's a very, very interesting day. Like I love going to work. It's a really interesting day despite all the challenges of medicine that are. So there's a lot tucked into that, but there's a million books about time management. I think I kind of do this time blocking technique where you kind of isolate various amounts of time, but then you're fully present where you are and you realize that actually most of what you do in your shared time together, for example, at work, should be anchored toward relationships, not isolation, not sitting in your office or anything. So that's kind of how I work.
Awesome. I think to be mindful of everyone's time, we'll go ahead and wrap up the Q&A part there. Thank you so much for all the questions, for the submitted questions, and for those who asked a live question. And of course, thank you so much, Dr. Han, for the very thoughtful answers and for your wonderful talk today. I'm going to pass it over to Kayla just for some closing reminders today.
Hi, so just as a reminder, the recording will be released sometime in the near future, so just look out for that. And yeah, that's all. I'll pass it to Nick.
All right. Thank you guys so much. We'll see you back in the fall with another set of great courses for you, hopefully. Have a great night,
Hey,
everybody.
Nick, thanks so much for having us. And I do appreciate everybody for sharing their time on Zoom. I am very accessible. If you have any other questions I didn't get to, please don't hesitate to let me know. The email is just ian-han@uio.edu. And the world's your oyster. It's a beautiful place and every day is precious. Please take advantage of all of it. And I'm very jealous of all of you in your position. There's lots of things to explore. So feel like you do have a lot of interesting things that you can be doing with your life. So look forward to seeing you guys down the road.